I'm Don Hood, and this is a symposium that is part of the iRise virtual Congress sponsored by Topcon Healthcare. The topic today is OCT and glaucoma diagnosis. Now, I've had over 10 years experience helping clinicians interpret OCT images. Okay, so let's start with the tutorial. So I'm going to describe an approach to understanding and detecting glaucomatous damage. And first, my obligatory financial disclosures. I have grants from both Topcon and Heidelberg, as well as equipment. Now, I'm going to address two questions in this brief tutorial. First, what should I look for in an OCT glaucoma report? And second, where can I find it on my particular instrument? This approach that I'm going to describe and the reports I'm going to describe really were based upon a one-page report for detecting and understanding glaucoma that a student, Ali Raza, and I developed in 2014. At that point, it was based on our experience of helping clinicians with OCT for about 4 or 5 years in 2004, by the time we got to 2014. All right, so here's the one-page report. In this case, it's based on 2 cube scans. One cube scan here is centered on the disc. The second is centered on the fovea. You'll see in a couple of minutes that the important point here is that the OCT scan covers both the macula and the disc. And in some cases, you can do that with a single scan. All right, so this is really more than just a report. It's a process or a method. And I'm going to talk about 4 principles or rules that we use. The first rule is you want to examine the circumpapillary B-scan image, and you want to examine it for glaucomatous damage and as well as segmentation errors. So if we blow this up here, it should be large enough and of clear enough resolution that you can see whether the segmentation is accurate, as indicated by the green lines here, and whether there's damage, as you can see locally right there. Right? Now, there are 2 ways you can get this particular image. You can actually get it from a circle scan that's scanned around the disc, or more commonly these days, you can get it derived from a thickness plot. So you can get it derived from this here, for example. And again, you're going to be looking for segmentation and image quality, how well the lines segment this, and you're going to be looking for damage. Excuse me. Okay, the second rule. You want to look at ganglion cell and retinal nerve fiber layer probability, or sometimes called deviation maps. This is essential. So these maps are based on thickness maps, which are also useful. And let me remind you of what a thickness map is before I tell you what the probability map is. So from this cube scan here centered on the disc, this is one of the B scans that make it up. We're going to get retinal nerve fiber layer thickness. And this is a pseudo color plot here of the thickness. And the way you read this is red is thick and blue is very thin. From the cube scan centered on the macula, or the fovea, we're going to get both retinal nerve fiber layer thickness and ganglion cell thickness. So that's retinal nerve fiber layer thickness, that's ganglion cell thickness, and again, dark red is thick, blue is thin. Right now, to get a probability or a deviation map, what the software does is it compares these thickness maps to normative control values. So when you compare this to normative control, you get a probability map here, and now red is bad, and in particular, red means abnormal at the 0.1% level, and red would be 1%, green, yellow would be 5%, and green's within normal limits. We're going to flip this along the horizontal meridian, just the way the image on the back of your eye is flipped, to get a field view. So that damage there corresponds to this damage here, right? And the reason for this is we're going to compare later on this damage to visual field points. So there are the locations of a 10-2 visual field. Okay, so We're also, so this is the probability map for the ganglion cells. This is the probability map for the retinal nerve fiber layer. And again, these are in field view. So this is based on this and this stitched together, field view. And again, dark red is highly significant at the 0.1% level. Green would be within normal limits. And then this, as I've already described, is the ganglion cell thickness map. All right, rule number 3, you want to look for topographical agreement of glaucomatous damage within a report. So let me unpack that. What we're looking for is something that's characteristic of glaucomatous damage, and that is typically an arcuate. So I want to remind you that because the axons from the ganglion cells arc around the fovea when they enter the disc, and because glaucoma acts at and in the disc, damage here creates this classic arcuate kind of pattern. So you're going to be looking for damage that's arcuate in nature. The second, which I'll define better in a moment, is everything should agree. That is, the different parts of this report should agree. Now, to make that easier, what I'm going to do, or what we recommend, is that this get presented in an end-stin plot, where T stands for temporal, and that's the middle of this. So you might say, what's an end-stin plot? All right, so let me take a moment to describe that. So in a sense, what you're doing is if this is the center of fixation here, and this is an 8-degree, plus or minus 8-degree circle, this is plus or minus 8-degree on your thickness plot. To understand this, let's go back to what you're more used to. What you're used to, starting with the very earliest Zeiss reports, is what's called an end-stin, a Tsnip plot often. And that is called a Tsnip plot because it is plotted the way the scan goes, which is from temporal, T, to superior, S, to nasal, N. You get the picture, Tsnip. The problem with this particular plot, when you're trying to understand the relationship to topographical parts of the retina, is that it splits the macula in half. So that's plus or minus 8 degrees now split in half. Whereas if you plot it as an end-stin, that is, you plot it as if it starts in nasal. So now it goes nasal, superior, temporal, inferior, nasal, end-stin. Now the macula is in the center of the plot. This is the temporal half of this region, which I'll show you in detail in a moment, would represent on your visual field about plus or minus 15 degrees plus the nasal step. So here's a little diagram. This is the region that represents the macula, which is plus or minus 8 degrees. This is the temporal half here. So this is the temporal half. And that temporal half represents about plus or minus 15 degrees plus the nasal step. So let's go over here. And this is the region of the retina that's represented by this region here. And so if you put on the 24-2 visual field points, you can see that the temporal half is about plus or minus 15 degrees plus the nasal step. Okay, so back to this. We're looking for damage that is arcuate in nature, and everything should agree if it's glaucoma and not an artifact. So what everything should agree is in this, let's use this as an illustration. You can see that this is thin. This is the region that's being affected by glaucoma here. That region corresponds to this here and corresponds to an arcuate that looks like something about like that. So this location here is topographically identical to this location here. It's identical to this location here and is associated with this arcuate. Okay, the final rule is if you want to compare the visual fields, which is one of the main clinical objectives, you want to use probability and deviation maps from the 24-2 and 10-2. You do not want to use visual field metrics such as mean deviation, pattern standard deviation, or glaucoma hemifield tests. So let me give you an illustration. Here's the 24-2 for this patient. You can see there's a nasal step here. These are the points that are abnormal here, right? And you can see it's consistent with an arcuate, right? But notice this can miss macular damage. This is why it's so important to get 10-2s. So here's the 10-2 for this patient. You can see some damage here, right? We'll put the points over here, add the abnormal regions, add them here, and you can see that in this case here, and this is not atypical, that you've got clear macular damage confirmed on the 10-2 that's being missed by the 24-2. Anyway, rule number 4, don't compare metrics, compare probability maps. Compare this to this. Now you might be saying, but wait a minute, aren't you assuming that we can compare abnormal regions? And I would say, yeah, that's what I've been saying. And you might say, well, wait a minute, I've been taught that structure comes before function. Well, the truth is that is not technically correct. If you use probability maps like this for both ganglion cells and visual fields, and if you compare it to local abnormalities on the field, then structure function agreement occurs in the overwhelming majority of eyes. All right, so that's the answer to the first question. The answer to the second question, I'll be brief because we're going to review this in our next section. And that is, where can I find this on my instrument? So we're going to be showing reports in a moment from 3 different manufacturers. We're going to be showing a report from Zeiss, a report from Heidelberg, and a report from Topcon. So let's do the Topcon first. The Topcon report, which is called a 3D wide field glaucoma report with visual field test points, or the hood report, is available for the Maestro instruments and for the Triton outside USA. And it's based upon our lab report. It's also based upon a 9x12 single scan. So this 9x12 scan includes both the macular region and the disc. If we take one of the B scans and blow it up, what the algorithm does is measure retinal nerve fiber layer, it measures ganglion cell layer, and it produces this report. This circular image here is derived from the same cube scan. Okay, so again, this is in N-stin, so that if we blow this up, you'll see this is your macula plus or minus 8 degrees. This is your temporal half, which is plus or minus 15 degrees plus the nasal step, N-stin. So remember, rule number 1, you want to examine this for glaucomatous damage and segmentation errors. There's some damage, and you can see there's no segmentation error to speak of. Rule number 2, you want to take a look at ganglion cell and retinal nerve fiber layer probability maps. So again, let's review. This is the thickness map. This is the probability map for the ganglion cells. This is in retina view. This is flipped along the horizontal to be in field view. This is the thickness map for the retinal nerve fiber layer. This is the thickness map. This is the probability map for the retinal nerve fiber layer. Rule number 3, we're looking for topographical agreement of glaucomatous damage. And all of these red arrows are topographically identical points. So we should be seeing similar things. Red here, defect here, thinning here, thinning here. These black arrows are also topographically identical, and they're consistent with the arcuate that's associated with the red arrows. And we'll come back to that point more than once. All right, the Heidelberg report, also based upon our lab report. There's a US version, and then there's a version available outside the US. We're going to be presenting this one because it's got the probability maps. So again, retinal nerve fiber layer thickness map, retina view, ganglion cell thickness map, retina view, N-stin plot. You can see the same places with agreement. This is the same eye. All of that's in retina view. Over here in field view, we have the retinal nerve fiber layer probability map and the ganglion cell probability map. The one thing that Heidelberg does differently that's different than the Zeiss and different than the Topcon is, in addition to showing significantly thinned areas, it shows significantly thick areas. So the other maps, this would be 1%, this would be 5%, and this would be 5 to 100%. In this case, they show significantly thinner. So if you want to make this, if you want in your mind's eye, if you want this to look like the plots I've just been showing you, turn all these to green. Finally, the Zeiss report, right? This is the one that you're most used to. It doesn't include the ganglion cell scan. There's a separate ganglion cell report that I'll show you in a little bit later. But for now, I just want to tell you we're going to be using the Zeiss Panomap because it has some of these same characteristics. In particular, this is based on 2 cube scans. This photo is not from the same eye. And so you get thick, this shows you the retinal nerve fiber layer thickness map for these 2 cube scans. So that's the thickness, retinal nerve fiber layer thickness associated with this scan. This is the one associated with that scan. And here are your deviation probability maps. Now, it's a little tricky because the deviation probability map combines the retinal nerve fiber layer probability map with the ganglion cell probability map. And we'll review this again when I show you the first case in a couple of minutes. This is a derived cervical scan, just like I was telling you about. In Tsnip, I believe the software now allows you to click a toggle and get instant. All right, so we'll review those reports again in a moment, but this wraps up my tutorial. I just want to mention my collaborator of 10 years, Gus Demores, and all the examples here actually come from a data set he's been working on, and the patients were referred by our colleagues at Columbia. Here are 2 short reviews that we wrote for the clinician that's available. And here are 2 longer reviews if you're really a glutton. And then you can visit my website and actually get these papers, but also recorded lectures that I've done in the past.